Alrighty, hello everyone, and welcome to the protein synthesis inhibitor chat. I am Colin. I am currently a P4 in pharmacy school, and I decided, hey, while I'm learning all this stuff, let's record it and post it to YouTube. So I hope you guys enjoy this. If you're a pharmacy student, this might be very beneficial for you, and we'll see how it goes. So these are protein synthesis inhibitors. We're talking specifically about aminoglycosides and macrolides today. So we're going to check out the mechanism of action, mechanism of resistance, synergy, black box warnings, pharmacology pearls, adverse reactions, drug-drug interactions, and we want to not only recognize black box warnings for aminoglycosides, but list them. These are low-hanging fruit for exam questions, so you want to know these very well, and then recognize macrolide pearls and describe the D-test. So here are a couple abbreviations. This is not necessarily an all-inclusive list, but it's most of them, and it's also alphabetically ordered, I think. I hope. So let's talk about antibiotic history real quick. I understand that we're here for macrolides and aminoglycosides, but I really want to take a look back and see why we care about antibiotics. So traditionally, we can find poultices and moldy bread that was used to treat wounds more than 2,000 years ago. And the Ebers Papyrus from 1550 is the oldest preserved medical document ever. And it listed moldy bread and medicinal soils in its remedies. And then recently, an Anglo-Saxon recipe was tested. An Anglo-Saxon recipe from 1,000 years ago was tested, and it was shown to kill MRSA. So those are the earliest instances of us using things to kill bacteria, but they're not really antibiotics. So the first antibiotic was developed by Paul Ehrlich and Sachihiro Hata in 1910. Paul's very commonly referred to as the father of antibiotics or the father of chemotherapy, but Sachihiro played a big part in the development of salvarsan, which was also called salvation arsenic, or 606, which was the number of, it was a chemical entity, the 606th chemical entity that they tested, and it was a success. It was used to treat Treponema pallidum, and which was the causative agent of syphilis. So they really developed what we now know as modern antibiotic medicine. So if we look at a timeline, we can see salvarsan was created in 1910. It was the first antibiotic used clinically, the first synthetic. And as you go down the line, you can see there's really just a golden age here between about 1940 and 1970 almost. And in that time, macrolides, polymyxins, nitrofurans, lincosamides, quinolones, so many drugs that we know and cherish today were created. It's amazing how many was really made in that time. I find it very interesting that this is right at the end of World War II, right in the middle, right in the end. It's right in there, and the amount of innovation during that time was insane. So speaking of World War II, aminoglycosides were discovered in 1944, and then they were introduced clinically in 1946. They were isolated from the Actinomyces streptomyces griseus, and you can tell by their name what they were originally isolated from. So aminoglycosides with the mycin, with the Y, they were originally pulled from a streptomyces group, and then if it's a mycin with an I, it's pulled from a micromonospora group. In the macrolides, they were discovered just a couple years later, 1951, and then they were introduced only a year later. There is some conflicting information about when it was actually discovered versus when it was introduced, but this was fairly roughly accurate. We'll take it. You're not getting tested on it, so. And then they were isolated from the Actinomyces streptomyces venezuelae, and several species of Micromonospora also produce macrolides. So you can see streptomyces and Micromonospora produce both aminoglycosides and macrolides, which is awesome and crazy. And the macrolides, it starts with the word picro. The very first one starts with the word picro, which is a Greek word for bitter taste. So I guess they tasted this and it didn't taste very nice. And then streptomycin was the very first aminoglycoside found. So here's just a quick little diagram, I guess, of some relevant aminoglycosides in today's practice. So we just started with streptomycin in 1944. All the way later in 1963, we got gentamicin, which we still use today. 1967, tobramycin. 1972, amikacin. All these three here are still used today. I see them fairly often. And then plasmamycin was created in 2018, which I have not seen in use yet, but it was new enough that I said I have to include it. So if we look at the macrolides, we have picromycin back in 1951, erythromycin just a year later. Who all knows about erythromycin? Everybody knows about erythromycin. And then erythromycin was altered chemically to create clarithromycin, it's a hard word, and azithromycin. And you can see here the little chemical alterations that were made to create these different compounds. So clarithromycin and azithromycin are both chemically altered versions of erythromycin. So why are there no new antibiotics? If we ignore plasmamycin, we really just don't see that many new antibiotics. You know, we're getting new diabetes drugs every other day, it seems. But what about antibiotics? Well, there was just such a rapid discovery during the golden age that it led to overuse of antibiotics and few incentives for further research. If there are so many antibiotics flooding the market, why should I keep looking? It seems like everything's covered. They were easily cultivated back in that time. They would take a little shovel of dirt, look through it, and then see if there was anything useful then. And they thought, hey, we've looked through all the dirt. We now know that we, in fact, have not looked through all the dirt, and we're constantly finding new things. But the more easily cultivated ones had been found. We're looking through new, underexplored parts of the world now. And also, the easily cultivated ones we found. But what about things that don't grow as quickly as strep? What about like a Clostridioides that grows slower? So the easily cultivated ones were found, but now we have better technology that helps us cultivate harder to grow bacteria where we could possibly find new compounds that can fight other bacteria. So you say, hey, find another bacteria. Bacteria fight each other. Of course they do. It's called antibiosis. Similar to how organisms in the wild fight each other, bacteria have to fight each other for food, you know? So how do they fight each other for food? Well, it's a dynamic antagonist interaction. They both excrete different strains of compounds that will kill or harm bacteria that they're fighting with. So that's why we use bacteria to fight bacteria, because they can produce things better than we can to fight other bacteria. If we look right here, we see a little chart of all the antibiotic groups that we have. Look how many of them are synthetic versus how many of them we found in nature and altered maybe a little bit. But the fully synthetic ones, it's just a handful. We got 5 groups there versus the, 20 that are made by nature. So where are they? Currently, they're working on them. The World Health Organization said in 2021 that there were 27 antibiotics in the pipeline. This number fluctuates. It's really hard to tell. There's always stuff in clinical trials, and this didn't really clarify between are they new antibiotic classes or are they alterations? Like, is it imipenem cilastatin, or maybe it's a new mix between imipenem and vaporbactam or something, So there are 27 antibiotics in clinical development, but we won't really know until they come if they're new or not. So while we chat today, I want you guys to think about this question. Can you use 2 protein synthesis inhibitors at the same time? I want you to think about this question and think about, can you use 2 cell wall active agents at the same time? Can you use cephalosporins and penicillins together? So let's get into the mechanism of protein synthesis, the protein synthesis physiology. So we have a nice little chart here, and we have a little key over here. So charged tRNA carries amino acids to the acceptor site on the 70S ribosome. Acceptor sites also referred to as the amino acyl site. So this is the A site right here. So this tRNA goes down and plugs in right there, okay? On step 2, this little chain here kind of swaps over and forms a connection right there. The amino acids group together and they continue to form the chain. The P, or the T5 right here, leaves. Once it loses its amino acid, it is an uncharged tRNA, and things just kind of scoot along. The T6 moves to the P site to get ready for another one to come in, and it's just a cycle. It's like a zipper going down and unzipping, but instead of unzipping, you're just creating a protein. So there's actually a wonderful little video right here. So we see the little mRNA goes through there. The tRNA comes and attaches in the A site. It swaps over to the P site. Then another one comes into the A site. The amino acids at the top, they bind, boom, forms a chain, and then it leaves in the E site. And it just repeats. This process repeats, and it grows the polypeptide chain, or a protein. So how do aminoglycosides work? I went through that because I want you guys to know how normal protein synthesis occurs. So how do aminoglycosides work? So of course, it's going to disrupt that process somehow. So initially, aminoglycosides diffuse through porin channels from the outer membrane. This is a gram-negative cell, so remember, there are two little membranes here. So they passively diffuse through the porin channels into this periplasmic space. And then they're transported across the inner membrane into the cytoplasm by an oxygen-dependent process. That will become important later. It's an oxygen-dependent process. And the electrochemical gradient provides energy. So you can see the hydrogen moving back and forth to provide the energy for this process. So that's how it gets inside the cell. But how does it actually work when it gets into the cell? Well, there's kind of three different mechanisms. So there's interference with the initiation complex of peptide formation. So aminoglycosides bind to the 30S subunit, and they kind of jam things up. You know, if it prevents the initiation, then the peptide can never start to form at all. It can also break up polysomes into non-functional monosomes. So it can get there, right? Say something is already being made along the chain, and it gets there and it plugs up the process again. And the polysome, which would have been if multiple amino acids combine, we would call that a polysome. It just prevents amino acids from combining and joining together. So it makes a monosome. So it blocks elongation of this little protein right here. And then it can just cause misreading. So the tRNA and the mRNA, they're supposed to have matching codons, right? But if there's an aminoglycoside in there messing things up a little bit, then it can cause misreading, and then it would incorporate the incorrect amino acid that could cause a chain, a protein chain that damages the inner membrane. And that's over here. This is just hypothesized. This isn't confirmed, but it's hypothesized that the mistranslated chains actually damage the inner membrane and allow aminoglycosides to enter more easily or more readily. So what's important here? There's irreversible binding to the 15S RNA, which is a little strand of RNA that makes up the 30S subunit. It irreversibly binds the 15S RNA of the 30S subunit. If you're ever asked what the mechanism of aminoglycoside is, the answer is going to be irreversibly binds to the 30S subunit. Because of that, it creates a bactericidal effect. This kills bacteria, right? It messes up. It has multiple mechanisms in how it prevents protein synthesis. It's concentration dependent. It is a concentration dependent mechanism because it has to get across this membrane. If the concentration outside of the membrane is not high enough, it will not passively diffuse through the porin channels. So that's why we monitor aminoglycoside concentration. One reason why we monitor aminoglycoside concentration. And then it exhibits a post-antibiotic effect because once it's inside the cell, it's doing its job. So even if you stop giving aminoglycosides, if it has made its way into the cell, it's going to do its job until all the cells are dead or all the aminoglycosides gone. So just a couple frequently asked questions about RNA synthesis is, why does the 30S plus the 50S subunit equal 70S? So this is a ribosome right here, right? This is a bacterial ribosome. Why does it equal 70S? Why does 30S plus 50S not equal 80? That would make sense. It would, but this is not math. The S stands for Svedberg coefficient, and it's a measure of sedimentation rate. So when they join together, you can kind of see an overlap there. You can assume that they would settle differently than if they were separated, but they would also settle differently than if it was just addition. So it's not calculated arithmetically. It is just based on their sedimentation rate. So we're taking these drugs that cause damage to bacterial protein synthesis. Why is it not causing damage to human protein synthesis? Well, luckily, they have different ribosomes than we do. The ribosomes in bacteria are structurally different than they are in mammals or humans. So it's a prokaryote versus a eukaryote scenario. So we have the 60S and the 40S, which equals 80S. And then they have the 30S and the 50S. So the drugs are so specific that they only bind the prokaryotic bacterial ribosomal subunit. They don't bind to ours, ideally. So how does resistance occur in aminoglycosides? So the main one to remember is decreased permeability. So there are ways that permeability can be decreased in these bacteria. One of the ways is the change in porin channels. There could be a mutation that causes less porin channels to be on the outer membrane. Well, since there are less porin channels on the outer membrane, that means aminoglycoside can't get in, and then that means that bacteria is resistant to aminoglycosides. I tried to illustrate each of these resistance mechanisms with a little red identifier. There can be increased efflux. There can be efflux pumps that say, hey, you're not supposed to be here. We're going to pump you out real quick. We're going to pump you out before you can do your job. There can be alterations to the 30S ribosomal subunit, which is right here. So if there are alterations, then it won't be able to bind. And if it can't bind, then it can't do its job. And then there's also just deactivation of the aminoglycosides. The bacteria can have enzymes that break down the aminoglycoside, similar to beta-lactamase for the beta-lactams. There can be enzymes that break down the aminoglycosides. So what are the aminoglycoside agents? Pharmacy students, this is where you perk your ears up. Gentamicin, tobramycin, amikacin, and neomycin. Really for inpatient use, gentamicin, tobramycin, and amikacin. More often than not, we'll see gentamicin, sometimes tobramycin. Toby is actually an inhaled formulation, so that's interesting. You can see that adjunct in pneumonia. Not often, but you can see it. And then we have some other lesser used kanamycin, streptomycin. That is the first one that was ever made, and it's still being used in places. And then plasmamycin, the new one, which is called Zimdri. So the aminoglycosides, what do they cover? Bug drug, what do they cover? So they cover gram-negative bacilli, pretty much. Because of the differences in the walls, they can't get through this thick peptidoglycan layer in gram-positives. So they'll cover E. coli, Klebsiella, Proteus, H. flu. My dog is kicking his bone around. And they just don't cover gram-positives. Or do they? Actually, they do. They can. But you have to have an agent to punch a hole in the wall for them to cover gram positives. So we have this massive peptidoglycan cell wall that aminoglycosides just can't penetrate unless they get help. If they get help from a beta-lactam, or if they get help from vancomycin, something that can punch a hole in this peptidoglycan layer so then aminoglycosides can get through the lipid bilayer and attach to the 30S subunit. So this is a term that we like to refer to as synergy in antibiotic therapy. Synergy means 1 + 1 is more than 2. It's 3. 1 + 1 is 4. So in this scenario, if we use two agents together, if we use something that punches hole into the cell wall, and then we also send a different drug in there to turn off protein synthesis, then you really have two really great mechanisms for killing for killing bacteria. And with that, you just have better killing. You have more efficacy, and you have synergy between the two agents. So, what are some unique coverage considerations for aminoglycosides? Well, amikacins typically reserved for more resistant gram-negatives, such as Pseudomonas or Acinetobacter. Gentamicin is normally the first line. It's the first gun that you pull out when you want to use an aminoglycoside. It's used in combo for synergy, for therapy for endocarditis, for example. And then neomycin is typically reserved for topical or oral local GI therapy. You guys know neomycin and Neosporin. It's one of the agents in Neosporin. People use it all the time. Cetobromycin has better nosocomial, however you choose to pronounce that, hospital-acquired. That's what it is. Hospital-acquired gram-negative coverage than gentamicin. So it covers hospital-acquired bugs better than gentamicin. But the problem is it has poor oral absorption. And it's got poor lung penetration, poor CNS penetration. So it's usually used in combination. This is why we have the inhaler for tobramycin. Since it has poor lung penetration, you can just inhale it, and then it gets there very easily. And then kanamycin and streptomycin are usually reserved for alternative tuberculosis treatment. So, aminoglycoside, pharmacology, all this stuff is very important. All aminoglycosides are renally eliminated and require renal dose adjustment. They are less effective in anaerobic and low pH conditions. If you know why that is, if you remember, it's because the penetration is an oxygen-dependent process. The penetration into the cell. That's why they are less effective in anaerobic conditions. They have to have oxygen. And then the pH conditions have to do with the balance of hydrogen ions, I believe. Yes. And then synergy with beta-lactams and endocarditis, gram-positives due to enhanced penetration. We've already mentioned that. Poor oral absorption. We've already mentioned that. They are used for decontamination of the gastrointestinal tract. And then there are some UTI indications. There's a primary indication in a UTI for a one-dose aminoglycoside. So you can see that used. So aminoglycosides, what's their black box warning? Well, nephrotoxicity, really. There's nephrotoxicity and ototoxicity related to sustained peaks of more than 12 micrograms per milliliter. And then there's neurotoxicity and ototoxicity related to sustained peaks. There's nephrotoxicity related to sustained troughs of greater than 2. You don't want to use them with the other nephrotoxins because they are very nephrotoxic and they can cause fetal harm. They used to be a pregnancy category D, but since those have changed, this hasn't really been reevaluated. And then tobramycin, it is associated with C. diff, but you don't see tobramycin that often. Aminoglycoside precautions and drug-drug interactions. So you want to be cautious with use with neuromuscular agents because they decrease acetylcholine release. Aminoglycosides decrease acetylcholine release, which can cause issues in myasthenia gravis or with paralytics that also either have decreased acetylcholine or decreased acetylcholine release. They can kind of augment each other. And then, of course, with that, you just want to avoid concomitant use with other neuromuscular blockers. So the dosing, the traditional, there's traditional dosing and extended interval dosing, or once daily dosing. It's typically based on what type of infection. So since there is poor lung penetration in pneumonia, you got to have a higher peak or a higher dose. So when you get to other things, like a serious infection, well, you don't have to dose it as much as long as it's not pneumonia. And then the UTI, since they are excreted renally, you can dose pretty low. Or with Synergy, you can dose pretty low because, the beta-lactams are doing the heavy lifting. So your gold trough is less than 2 micrograms per mil to reduce the risk of nephrotoxicity. And then the extended interval, once daily dosing, you can do 5 or 7 mg per kg every 24 to 48 hours. This is just the typical dosing strategy. The intervals allow for an undetectable trough for 4 to 8 hours, and they show less nephrotoxicity in patients with greater than 40 creatinine clearance. So a good rule of thumb here is higher peak means better killing. The higher you get that peak, the more drug goes into the cell and kills the cell. Lower trough, less toxicity. Toxicities that we're worried about, especially nephrotoxicity. That is the main one, but there's auto and neurotoxicity as well. So how are the aminoglycosides dose adjusted? They're dose adjusted renally. This is made for a in-person presentation. You guys are just getting the joy of hearing it online. So protein synthesis physiology. This is just a quick reminder of how protein synthesis works. You've got the tRNA hopping in here to build the chain of the protein or the amino acid chain. And then this quick little video. Let's see. Watch it again. And just a reminder how this works. Because if you know how this works, you know how the drugs work. So this little bubble down here is the 30S subunit. And this little bubble up here is the 50S subunit. You can see it building the amino acid chain. So, macrolides. We're halfway there. Macrolides reversibly bind to the 23S RNA of the 50S ribosomal subunit. They prevent the translation of mRNA by preventing the enzyme from adding subsequent amino acids attached to the tRNA. The enzyme that they prevent is called peptidyltransferase. That's not really relevant. You just have to know that it binds to the 50S ribosomal subunit and prevents the extension of that chain. They inhibit translocation by blocking the exit as well. So imagine a little tunnel over here where the amino acid chain's coming out. Sometimes the macrolides are a big molecule. Sometimes they get stuck in there and they just kind of jam things up. It's like a traffic jam in the tunnel. They reversibly bind, which leads to a bacteriostatic effect, because if they bind reversibly, well, they can kind of be nudged off of their home. If they're stuck in here and they're not bind irreversibly, then they might get kind of pushed out. And if they get pushed out, the bacteria is not dead. They do exhibit time-dependent killing because creating this RNA chain, it takes time. Creating the amino acid chain, it takes time. So it has to be in its area of effect long enough for it to actually do its job. If it comes and leaves before the next little part is attached, well, it's not doing its job. It's got to be there long enough. So how does resistance occur? Mainly through drug inactivation. So esterases hydrolyze the macrolide. You can see that here. Hydrolysis occurs right there, snaps it open. Drug just doesn't work if it's not exactly right. And you can also see here, this is a big drug. This is a big little chain there. And then once it snaps, it'll probably unravel and be a lot longer. It's just not the same. There are alterations that can occur within the 50S ribosomal subunit. So the binding site could change, and that would prevent it from binding. Or the way it enters the binding site could get smaller, so it's harder for it to fit. There can be increased efflux, very similar to the aminoglycosides. It can just kind of pump the drug out of the cell. And then there can be cross-resistance with clindamycin. This is called MLSB resistance or MLS type B resistance. MLS stands for macrolide, lincosamide, streptogramin, and it is inducible resistance that is tested with the D-test. So what's the D-test? The D-test is a test looking at if there is inducible resistance against clindamycin. This is tested by dropping a little pill of erythromycin and clindamycin beside each other in a petri dish. And if the clearance around the clindamycin looks like a D, that means that the erythromycin turned on a gene that causes resistance to clindamycin. I believe it's called the ERM gene. But if that happens, then macrolides would then induce resistance to clarithromycin, which is a lincosamide. So what are the macrolide agents? There's azithromycin, clarithromycin, and erythromycin. I'm sure you see azithromycin all the time. Erythromycin is often seen as a ophthalmic ointment, but there are pill forms as well. Coverage and considerations. It's fairly broad. It's got some gram positives, some MSSA, strep pneumo, strep pyogenes. It's got gram negative coverage in gonorrhea, MCAT, H flu, jejuni, pylori. And then it covers some unusual / atypical bugs. There's the Treponema pallidum, which is the syphilis bug from the start of the lecture. Toxoplasma gondii, Listeria, M. avium, C. trachomatis, and M. genitalium. So, what makes unusual, it's just they don't follow the traditional gram-positive or gram-negative cell wall. Some of these are parasites. Some of them are bacteria. It's just kind of a case-to-case basis type thing. So macrolide pharmacology. All agents undergo hepatic excretion. Although clarithromycin's also renally eliminated, so you have to renally dose adjust it. It seems like a little bit of a conundrum, but it's possible for both to happen. Clarithromycin is also an inhibitor of CYP3A4, as well as erythromycin. They're both CYP3A4 inhibitors, so if you're going over a drug regimen, make sure to check to see, is this going to affect any of the other drugs that they're on or that they're taking? Erythromycin also has a solution, and the solution is stable at room temperature. Azithromycin, everybody knows about a Z-Pack, but what about Z-Max? It's a suspension that you don't refrigerate, and you have to use it within 12 hours. And it is not bioequivalent with other formulations, so you have to have specific dosing for the Z-Max suspension. The azithromycin concentrates in the neutrophils, macrophages, and fibroblasts. So that's why you have to kind of give a little loading dose. You give the drug, it's in there, and it just works. It slowly releases from the neutrophils and macrophages, and that's what gives it the long half-life and why you have to give a loading dose. Azithromycin is not associated with CYP3A4 interactions, though. Some precautions and side effects of macrolides, really QT prolongation, especially with erythromycin and clarithromycin. You have to watch their QT interval or their QTC interval. It does cause cholestatic hepatitis, especially with erythromycin estolate, the salt form, and use with caution in patients with hepatic dysfunction because it's hepatically eliminated. Side effects, GI, especially nausea, vomiting, diarrhea, cramping, and then the interesting one, it actually stimulates motilin receptors, which is most common with erythromycin. So sometimes in the ICU, you might see somebody that they give erythromycin just to get their gut working again. So it's not a chronic use type thing. You will gain a resistance to it, but you can use it acutely to get a little bit of prokinetic going on, a little prokinetic agent there. So Drug-drug interactions, again, QT prolonging drugs. You do not want to prolong your QT interval. Erythromycin is a strong 3A4 inhibitor, so watch out for other 3A4 drugs like lovastatin, simvastatin, warfarin, apixaban, dabigatran, theophylline. You got to watch out for those. There's a ton of them. It seems like every drug is a 3A4 inhibitor or inducer. You got to check that stuff. Clarithromycin, it's similar to erythromycin, but to a lesser extent, so it's kind of a little nicer. You know, if you think back to what clarithromycin is it is a chemical altered form of erythromycin. So it makes sense that their side effects would be very similar. And then azithromycin, it's a weak CYP3A4 inhibitor. It's kind of a puny guy, but similar things all around. So what is used to check for inducible resistance? It's called the D test. It uses erythromycin and clindamycin to check for macrolide inducible resistance to clindamycin. And now that we've reached the end, can you use two protein synthesis inhibitors at the same time? I don't know if you thought about it a lot, but in theory, yeah, you can. In reality, you can. Since they work on different areas of the 70S ribosomal subunit, you could use a macrolide to hit up here and aminoglycoside to hit down here. There are different things to think about in terms of, well, macrolides are big molecules, so they might kind of not leave enough room for the aminoglycosides. There are other little clinical conundrums like that to work through, but as a blanket statement, yeah, you can use two at once. You can. So if there are any questions, please leave them in the comment. If I have anything wrong in this, please feel free to correct me and leave a source. That'd be great. I have a few extra slides here in case you guys are curious. You can pause it and look. This is just additional figures for protein synthesis. There's two there. I don't know which one might work best with your brain. And then I have two additional aminoglycoside slides that help explain its mechanism. And then I have two more macrolide slides. And then there's a video here that I will try to remember and put in the description. So if you need it, you can use it. It's a very good video, very clean and very fast to show you how macrolides work and how they form resistances. So I hope you guys enjoyed this. This is the first time I've really done one of these on YouTube. Normally I prepare these for class or for rotations, and I just don't ever make use of it anywhere else. So if you guys like this, let me know, and maybe all my presentations going forward, maybe I'll make a different version for the video form. But thank you very much. If you enjoyed or found anything wrong, let me know. I'll see you next time.